Zerny endovascular aortic arch repair, the double branch. He's from Germany. Ivan, the next. Dr. Stephan Langer, Germany, fenestrated FEVAR in juxtarenal abdominal aortic aneurysm.
Yeah, dear Mr. Chairman, ladies and gentlemen, thank you for this kind invitation. It's the first time for me to be in Egypt, and I really enjoy it, and I'm proud to be a part of this session. I hope I can give you, I can share my experience with fenestrated EVA with you, and how can I move on this like this? Okay, I have no disclosures concerning juxtarenal aneurysm and FEVAR. Yeah, what means juxtarenal? It's very easy if you do op repair, and I think most of you do this every day. You need a suprarenal clamp, and when you perform endovascular, you have a short neck below 10 millimeters, and this is normally not the insufficient sealing zone for standard EVA. And what can you do? You can try to do EVAR, and this is the famous Schanzer paper, which told us that nearly 1/3 of all standard EVARs are performed outside the IFU, resulting in bad long-term outcomes. For example, like in this case, a patient who came from outside with this contained rupture, this patient was treated with a chimney technique in an emergency setting. So what can you do? You can use endo anchors you fix your stent graft below the renals, and you hope that it will not migrate in the future. You can use the chimney technique, which is a nice technique in an emergency setting, but in my opinion, it's a kind of fenestration for the poor. It's because you have the problem with the gutter endoleaks. However, it's a helpful technique. I want to tell you something about FEVAR, which was introduced 18 years ago by this Dutch group. They published the first 18 patients who were treated with this Cook-Zinit endograft with 2 fenestrations for the renals and 1 scallop for the mesenteric artery. And as you can see here, this technique gained wide acceptance. You see this increasing number of publications concerning fenestrated EVA. And in 2010, a next device was on the market. It's the Anaconda endograft from Terumo Aortic, and it's based on the standard endoprosthesis. And the idea is to extend the landing zone above the renals in a healthy aortic segment. And this stent graft has a few good advantages. For example, you can do a repositioning. And it has an unsupported body structure similar to the standard Anaconda 1 lock. If you want to start with this technology, I would recommend to do a simple case. And what's the meaning of simple? It means that you have still a very short infrarenal neck. The renals should be right angled, and if you have a large distance between SMA and renal artery above 7 millimeters, you can do a 2-fold fenestration, which is easier than 3 or 4-fold. Of course, you need adequate access vessels. I show you an example from 2012. It was a simple, I would say, a simple 3-fold fenestrated Anaconda. This was our draw, and as you can see here in the device product request form, that we have at 8 millimeters distance between the celiac trunk and the SMA, so you can make a 3-fold fenestration. At this time, you always got this 3D model, and you were able to put this model in your cath lab and make a kind of a prototype implantation. And this is a straightforward case. It's very straight, right angled, and here you see the cannulation of the right renal artery, the cannulation of the SMA in a rotated by 90 degrees, and the stent deployment of this covered stent. Then cannulation of the left renal artery, and what I want to show you here is that when we started with this technique, we always came from above to for the celiac trunk and the SMA, because we were a little bit frightened above because of this steep ankle. So this was the final angio, and so it's always the same cascade. You start with the diagnostic, your CT scan, you make your measurement, you get the model, you go in the cath lab, make your procedure, and this is the post-operative CT scan. Yeah, then we had a kind, I would say, like it was a game changer. It was the introduction of this tour guide sheath. It's a steerable sheath, and you can use it with different angles, and that makes it much more easier to advance a catheter into steep renal arteries or in the mesenteric artery or the celiac trunk. And since we have this sheath, we do all the target vessels from below. This is a very recent case. It's not a juxtarenal case, it's a thoracoabdominal case. First, we performed the TEVAR to have a perfect proximal landing zone just above the celiac trunk. Then we advanced the stent graft into the thoracic endograft, and we deployed with a 3 or 4 centimeter overlap here above the celiac trunk. Then we go on with the mesenteric artery, then the right renal artery, and here you can nicely see what we call flaring, which means normally the stent has a size of 6 millimeter diameter, and for a good fixation and a good sealing here, we use a 10 or 12 millimeter balloon to open this stent, and then you have a good seal. So this is the final result. So a short view to the literature, 3 multi-center studies showing a good technical success, a low 30-day mortality rate and a low endoleak rate. And very hot off the press is comparison of open and standard and complex endovascular aortic repair, showing that the perioperative survival benefit for FEVAR, which is lost after 2.5 year follow-up. A short view to the guidelines. In complex endovascular repair, it's recommended, but it's only a weak recommendation. In the American Society, there's no recommendation for this technique until now. So, taken together, the advantage is the avoidance of an aortic cross-clamping, lower risk of renal dysfunction, less surgical trauma, short-term benefits. Drawback is it's technically challenging. The device is expensive, in my opinion. A hybrid OR is mandatory, and it's not for emergency cases. So a custom-made FEVAR is a valuable option in selected patients. The devices are safe and the techniques are standardized. They have a high technical success, low perioperative mortality, and the long-term results seem to be similar to open repair. Thank you very much.